First of all, I'd like to introduce Dr. Shobhana Nagraj, who is a senior clinical lecturer in global surgery here in Oxford, and Grace Drury, who is program manager in the Oxford University Global Surgery Group, and they're going to give us a brief update on the Oxford Global Surgery course. Following that, I'm delighted to introduce Naomi Wright, who is a registrar in paediatric surgery at the Oxford Children's Hospital and the Wellcome Trust Clinical Doctoral Fellow at Oxford University Hospitals and the King's Centre for Global Health and Health Partnerships at King's College London. Naomi has previously worked on improving newborn survival in the Gambia, and with the help of Royal College of Surgeons grant, set up a large collaboration of surgeons and anaesthetists in sub-Saharan Africa to study paediatric surgical outcomes. Most recently, in her doctoral work, she has set up an interventional study in gastroschisis management spanning Ghana, Zambia, Malawi, and Tanzania, and also a global cohort study comparing management and outcomes of neonates born with congenital gastrointestinal anomalies in low, middle, and high-income countries. The latter study recently having been published in The Lancet. Just before I hand over, please could I remind everybody to turn off your microphone and camera during the talks. We will keep questions, if that's okay, for the end after all the speakers. And when they're finished, I would ask you to raise your hand or switch on your camera and wave to attract attention in order to ask questions. Thank you very much, and over to you.
Thank you. Thank you very much for the introduction. Hello, everybody. My name's Shobhi, and as mentioned, I'm going to be presenting about the Oxford Global Surgery course today, together with Grace Drury. So just to give you a little update on what the course is, it's an accredited short course which is accredited through the Department of Continuing Education, and it brings together 4 departments across the university: the Nuffield Department of Surgical Sciences, Endorms, Women's and Reproductive Health, and the Department of Clinical Neurosciences. There are 3 course directors, Professor Kekila Laku, Professor Chris Larvey, and myself. And the course started for the first time in 2018 and brought together over 30 participants from over 16 countries and a multi-professional faculty. And the course really started on the back of the Lancet Commission for Global Surgery, which, as well as highlighting this huge unmet need for surgical services across the world, also highlighted gross inequity in the provision of surgical, obstetric and anaesthetic services, especially in low resource settings worldwide. And one of the key things that came out of the Commission was also the need for global surgical education for people, trainees, both in high income and low and middle income settings. And so that's how our course came to be. And what's quite unique about our course is that we have a global multidisciplinary faculty that's spanning lots of surgical specialities, but also bringing in other perspectives from NGOs, parliamentarians, thinking about policymakers, health economists, and also public health doctors as well. And really at the heart of this course is the spirit of Ubuntu, which is I am because we are. So it's really quite apparent now in the pandemic that we can't ever do anything just for ourselves or our little hospitals. We really need to start thinking about the world and humanity as a collective. And so this is kind of at the spirit of our course. It was also designed for frontline healthcare workers. And this was recognizing the fact that they're under enormous service pressures in their own countries, and also incorporating their needs and listening to what they had to say about what was happening on the ground. And as a result of that, I think what's really interesting that's come out of the course is that we've really become a big family over the years, and there's ongoing connections and support. So just to introduce you to some of our faculty, we have a large Oxford faculty. It looks like we're missing one key person at the end there to fill in the square. And we also have a wider faculty, which is international, ranging from people from India, Bangladesh, Nepal, Sub-Saharan Africa, NGOs, as I mentioned, and also policymakers across the world. And what this really provides to the course are really in-depth, rich discussions with real-world case studies. So we're able to actually talk about case studies from countries such as Mozambique and provision of CMONC facilities there, looking at community health workers in rural Nepal, thinking about mobile paediatric surgical clinics in Ghana, and also how we train people in district general hospitals to do specialist services for surgery, and also how we address rural surgery as well. So the learning outcomes from the course aren't just focused on the provision of safe surgical services, but actually understanding that these are within the wider context of a health system and a country context as well. So it's really looking at the systematic understanding of these factors and actually acknowledging complexity and the fact that there's medical and non-medical factors that interact, that help us as surgeons provide services. And also bringing in this idea of surgical research to people that may not have engaged with research in their clinical careers, and thinking about contextually relevant approaches. So this is really the main focus of our course. We do pack in quite a lot in a week. So our curriculum covers aspects of the Lancet Commission on Global Surgery, but actually where we've come since then and what we need to be doing, and brings in elements of technology and its use in global surgery, how to provide safe surgical services and how to engage with research in global surgery, but also brings in ethics and advocacy and how we think about resource allocation at a more policy level, and thinking about building partnerships and working in new contexts. So I'm going to hand over now to Grace, who's going to say a little bit more about the students and a bit more about the course. So over to you, Grace.
Thanks, Shobhi. So we've had about 30 students each year who apply to join the course, and the course fee has been set for 2021 as £1,350 for the 1 week course, which is equivalent to 20 CAP points if they wish to use it to build towards another qualification. As Shobhi's mentioned, it's multi-level, so we have consultants, trainees and senior medical students and other allied health professionals. We have those from surgery, anaesthesia, obs and gynae, and a real international group of people. And we're grateful for bursary support, which has built year on year, which has helped us to widen the participation, and a number of donors, but in particular the Africa Oxford Initiative and Kids Operating Room have helped more people to access the course who would not otherwise have been able to. And with our alumni, I think it's been the course has been a springboard to help them to engage with surgical activities and public health in their own settings, including national surgical societies, research, going on to do more global surgery fellowships or education. And that's been great. And also podcasts on global surgery, the Global Scalpels podcast. Thanks. Next slide, Jamie. And so how we developed the course has been a real journey. And from the feedback from the 2018 first course, we then added topics on ethics and advocacy and resource allocation. These are themes that intertwine with all the different aspects of surgical provision, and have just enriched understanding for all of us to learn from each other as well. The first course had more high-income country students, and so it started off thinking, well, how could we possibly prepare these students for working in low or lower middle income country contexts. But actually, as the balance of students has changed, we've recognised it's really important to prepare everybody for working in a new context, wherever that may be, working from urban to rural or one country to another. And that's been really helpful to have that shift. This year, we've learned how to deliver the course in an online format due to the travel restrictions. We've got a glimpse of some of our students there. And so we'll take the learning forwards of the different formats in which we could deliver the course for next year and beyond. Thanks, JB.
Thanks, Grace. So just to highlight some of the feedback that we received, and I promise that I haven't cherry picked all of this. I have to say that actually the feedback in general has been overwhelmingly positive. The more critical aspects of feedback have really been that people want to explore things in much more detail and have a bit of a longer course. But I just wanted to highlight some of this feedback, which has really been around it being an amazing course, interesting, fascinating, and life-affirming. I can't recall the last time I enjoyed a course so much or got so much value from it, and I'm missing you already. And I think that conveys what happens during this week, is that everyone becomes a bit of a family and a support system. And so we get requests with, for example, here, which saying, are you sure we can't do another week? And I'd really like to read out this last quote, which I think really embodies the theme, the main theme of the feedback that we've received from the course over the last few years, which is, this course has embodied the meaning of global surgery. It has brought together people from all walks of life, allowed them to all have a voice, and explored how we as people can make partnerships and relationships that bring about change and equity in surgical healthcare. And this really goes back to what we've had at the heart of this course, which is this spirit of Ubuntu, which is I am because we are. And I think that's really reflected in the feedback that we've received. So what we're going to do from now on is that hopefully next year we will have a face-to-face course in September. We're expanding some of the course content to form a module, which hopefully can be integrated into other courses as well. And we would like to have a longer course, in the sense that this is the feedback that we've received, is that people want more. So we're really open to applications from people, and please do follow us on social media or visit our website and keep up to date with how the course is developing. So thank you very much. And if there's any questions after Naomi's talk, we'd be really happy to answer them. Thanks.
Lovely. Well, what an inspiring and amazing presentation. Thank you. I loved hearing about your course. And thank you so much for this opportunity to present. So I'm going to talk about the results of the Global PaedSurg study, which investigated the outcomes from gastrointestinal congenital anomalies across the globe, and then sort of discuss in a bit more detail about how neonatal surgical outcomes may be improved in low and middle income countries globally. So I just want to start with a bit of background to really put the study in the global health context. And thank you, Shobhi, for already mentioning the Lancet Commission. I'm sure people on this group have heard about it before, but I'll just touch on it now. So 2015 was really the year that revolutionized global health to really think about global surgery, and the global burden of surgical disease. Up until this point, really a lot of global health was focused on infectious disease, particularly HIV, TB, malaria. And it's since been discovered that the number of deaths from those three infectious diseases combined is less than the number of deaths from surgical disease across the globe each year. So in 2015, the Lancet Commission on Global Surgery reported that 5 billion people, so 2/3 of the world's population, don't have access to safe surgical care when they need it. In the same year, the World Health Organization incorporated essential and emergency surgical care into universal health coverage for the first time. This target was set to have 80% coverage of surgical care per country by 2030. And as a result, many countries across the world, low and middle income countries, started to produce national surgical plans for the first time, with the aim to exponentially scale up access to surgical care in those countries. This is important because before that, most national health plans in low and middle income countries focused mainly on infectious diseases with little focus on surgical disease. However, one of the concerns we had at that time was that there was very little data on children's surgical conditions, the management and outcomes in low and middle income countries. And we had a fear that children wouldn't get adequately represented in those surgical plans being developed. So we wanted a way to rapidly gain access to data from low middle income countries across the world on paediatric surgical outcomes we decided to first focus on sub-Saharan Africa, as that's where approximately half of the under 5 deaths from the globe occur. So we first established the PeteSearch Africa research collaboration, which consists of children's surgical care providers across the region. And we undertook a prospective cohort study looking at the outcomes of a selection of common children's surgical conditions spanning from the neonatal period up to teenagers at 16 years of age. And this is sort of highlighting, this slide's highlighting the key results. So you can see that gastroschisis was the condition with the greatest disparity in survival. So 76% mortality from gastroschisis across sub-Saharan Africa compared to 2% in high-income countries, followed by anorectal malformation, 11% in sub-Saharan Africa versus just under 3% in high-income countries. And indeed, so 89% of the deaths in the whole study were amongst neonates and the rest in infants. So this made us realise that we need to really think about studying a wider range of gastrointestinal congenital anomalies and in low middle income countries globally, not just sub-Saharan Africa. And that's really where the Global PaedSurg study was born. But first, before I go on to tell you about that study, I just sort of want to put congenital anomalies as a whole within the global health context. Where do they lie? Well, over the last 25 years, congenital anomalies have risen to become the 5th leading cause of death in children under 5 across the globe. It equates to about 500,000 deaths per year, and 97% of those deaths are in low and middle income countries. And you can see in the graph here that there's an increase in burden. So over the last 25 years, the focus has been on reducing deaths from infectious diseases, and very successfully. And you can see that the deaths from common diseases such as malaria, lower respiratory tract infections, diarrheal diseases continues to fall. But the number of deaths from congenital birth defects continues to rise. And indeed, there's been very little focus on improving care and outcomes from neonatal surgical conditions, primarily congenital birth defects. One of the problems has been very little data on these conditions from low middle income countries. Many LMICs don't have congenital anomaly registries like we have here. Most of the studies were sort of retrospective, small series, single institution studies. And there's particularly little data on GI congenital anomalies. So as most people will have heard of some of the big charities like Smile Train, Operation Smile, Professor Lavi's Clubfoot charity and others. Those charities have collected some data on those specific congenital anomalies, but there wasn't really a charity that focused on gastrointestinal congenital anomalies, and hence very little data had been collected on these conditions. So we expanded that PeteSearch Africa research collaboration to form the Global PaedSurg research collaboration. These are children's surgical care providers, so surgeons, anaesthetists, nurses, paediatricians, neonatologists, and other team members across the world managing surgical congenital anomalies, coming together to collect data on the management and outcomes of GI congenital anomalies across the globe. And prospective data was collected on 7 of the commonest GI congenital anomalies. This includes esophageal atresia, congenital diaphragmatic hernia, intestinal atresia, gastroschisis, exomphalus, anorectal malformation, and Hirschsprung's disease. And data was collected on consecutive patients presenting over a minimum of 1 month up to 7 months between October 2018 and April 2019. The primary outcome was all-cause in-hospital mortality, and we undertook multivariable analysis to identify factors associated with mortality. So altogether, over 1,300 children's surgical care providers contributed to data collection in 264 hospitals, 74 countries, incorporating 12 languages. And data was collected on just under 4,000 patients. So what were the outcomes? Well, again, gastroschisis was the condition with the greatest disparity in mortality. So 1% mortality in high-income countries, 32% in middle-income countries, and 90% in low-income countries. Now, that was followed by esophageal atresia with 7% in high-income countries versus 86% in low-income countries. Congenital diaphragmatic hernia, similar, but you can see that the cohort in low-income countries was actually missing. They just didn't present, and maybe they're dying in the community without a diagnosis. And then intestinal atresia, the fourth one down there. So what factors are associated with a higher mortality? Well, country income status, having a low or middle income country status were the factors associated with the highest risk of mortality. And then when we look at clinical factors, we can see that sepsis at presentation was associated with higher mortality, having a higher ASA score at the time of primary intervention, so being sicker at the time of surgery, not having a surgical safety checklist used or a physician anaesthetist present at the time of surgery, and in the perioperative period, not having ventilation and parenteral nutrition available when needed. And in terms of factors associated with a lower mortality, receiving parenteral nutrition or use of a PICC line or percutaneous central line are associated with lower mortality. So in conclusion, this study showed that there's unacceptable disparities in mortality for these common gastrointestinal congenital anomalies between low, middle and high income countries across the globe. And Sustainable Development Goal 3.2 aims to end preventable deaths in neonates and children under 5 by 2030, which clearly is not achievable without urgent action to improve neonatal surgical care and outcomes amongst patients with congenital anomalies. So what should we be focusing on? So 3 key factors: improving antenatal diagnosis and therefore delivery at the Paediatric Surgery Centre, which would avoid clinical deterioration prior to arrival. Improving district level resuscitation and timely transfer for those that are born in the districts. And improving the perioperative care at the tertiary level. So focusing on resuscitation on arrival, use of a surgical safety checklist and having ideally having a physician anaesthetist present at the time of surgery, and improvement in the perioperative care, so IV access, parenteral nutrition and ventilation for neonates. And these results were published in the Lancet. So just moving on to thinking in a bit more detail about how neonatal surgical outcomes might be improved in low and middle income countries. So I've sort of split this up into local, national and international action. So of course, the Global PaedSurg study already incorporated multidisciplinary teams in low and middle income countries across the world, which is fantastic. So those teams are already involved. They have these study results. They've been involved in the study. So they will come together, present the results locally at multidisciplinary team meetings, and discuss what can be done at the tertiary paediatric surgery centre to improve that resuscitation on arrival and the perioperative care. And then think about how can that faculty reach out to the referring hospitals to provide education and set up referral pathways to improve the condition that these babies arrive in. And also working with our ultrasonographer and obstetric colleagues to think about how can congenital anomaly screening in the districts be improved. And not only that, if these conditions are identified, how can we improve the referral pathway so that those mothers can actually deliver at the tertiary centre? Then looking at a national sort of level, what can be done? Well, those multidisciplinary teams can approach their local government representative, health minister, minister of health for the country, share the results, talk about how these things can be improved. Think about incorporating neonatal and paediatric surgical care into the National Health Plan, or indeed the National Surgical Plan if that is being developed. And the Global Initiative for Children's Surgery, which I'll mention in a moment, have published a set of guidelines on how that can be done. The guidelines state, what resources are required in terms of healthcare personnel, as well as physical resources at every level of healthcare within a low middle income country to provide, good neonatal and children's surgical care. And various countries such as Nigeria have already done that, which can be used as a template for other countries to follow. Clearly, there's a need to increase training numbers and staff in terms of paediatric surgery, anaesthesia, nursing, and antenatal ultrasonographers. So how can this be done? Well, the Kids OR charity have already donated approximately £100 million to train paediatric surgeons and anaesthetists across sub-Saharan Africa. So that's a huge first step, and will hopefully continue to expand in low middle income countries across the world. So the other thing is to sort of spread awareness amongst the local population. So we did, at the time of the Lancet publication, we did a big sort of media blast in local newspapers and press as well to sort of raise awareness amongst the wider public. And then at the international level, what do we need to consider? Well, there are WHO guidelines on newborn care. So there's recently been the Every Newborn Action Plans in many low middle income countries, and there's newborn care guidelines. And those at present, they have a generic focus, which would also benefit patients with congenital anomalies, such as reducing and treating neonatal sepsis. But really, if they incorporated a few more specifics about the management of congenital anomalies, that would hopefully lead to improved management and outcomes, because many staff members in district hospitals in particular follow those guidelines when managing patients. And there's ongoing work in terms of trying to set up congenital anomaly registries. The WHO has produced a sort of guideline for that, but many congenital anomalies are not included in that guideline, including many of the GI congenital anomalies that I've mentioned today. So that really needs updating and being made more comprehensive. So many countries across the world have population health surveys that are undertaken. Often they focus more on infectious diseases in children, and it would be wonderful to see congenital anomalies being included in those health surveys so that we really get a sense of the burden of disease related to congenital anomalies across the world. We obviously need to raise awareness amongst major global health funders. So obviously the Lancet publication is one way, but also collaborators in the study have been presenting the study results in countries across the globe and on social media across the globe in multiple languages. We need to, and through the Global Initiative for Children's Surgery and other organisations, we need to start incorporating more children's surgical care into organisational activities such as UNICEF, who have started to think more about children's surgical conditions, but the focus previously was more infectious disease and malnutrition and sort of medical conditions. And the Global Initiative for Children's Surgery has recently set up a congenital anomalies working group, which aims to sort of bring all of these stakeholders together and work towards these outcomes that we've mentioned today. So finally, in the last few minutes of the talk, I just want to touch on the other part of my PhD, which was the Gastroschisis interventional study. And that really follows on from sort of action to improve outcomes. So this study was focused specifically on reducing mortality from gastroschisis in 7 tertiary paediatric surgery centres in Ghana, Zambia, Malawi and Tanzania. All of these centres had across the board a mortality of around 98% prior to the study, and it was a clinical interventional study with multidisciplinary team leaders based at each of those centres. So just to sort of give you a taste of what that study looked like, we spent about 2 years planning the study in terms of doing lots of research, so systematic reviews, qualitative studies, consensus processes, to come up with evidence-based care protocols that were specifically adapted to the low middle income country setting. There was a core component of the protocol that was standard across the 7 hospitals, and then an adaptable component to optimize the care protocol to the local setting. I spent a year in Africa working with the teams at the tertiary centres. All the faculty was trained, the multidisciplinary team at the tertiary centre, and then that faculty went out to all the referring district hospitals to provide outreach training and set up referral networks to try and improve the condition that they arrive in, and then the care at the tertiary centre. So at the tertiary level, what was taught? Well, really just basic things, covering the bowel in plastic at birth to prevent heat and fluid loss and try and reduce risk of infection from the bowel, keeping the baby warm, giving IV fluid bolus, giving IV antibiotics, and transferring the baby to the tertiary centre as quickly as possible. And think about what local resources can achieve that. So we came up with a modified kangaroo mother care to keep the baby warm, skin to skin during transfer. And then at the tertiary level, the care protocol consisted of early resuscitation and then cot side application of a preformed silo with reduction of the bowel at the cot side and sutureless closure. So this avoids the need of neonatal anaesthesia and having to have, space for an operation and availability of a paediatric surgeon and anaesthetist, which aren't available 24/7. And then early establishment of enteral nutrition and the provision of IV nutrition. So they didn't have full parental nutrition, but we established IV nutrition using locally sourced amino acids and lipids in addition to the 10% dextrose. And that can be done very cheaply, about $1 to $2 per day. So overall, in the study, there was a reduction in mortality from 98% to 65% across those 7 study centres. One centre, Muhimbili in Tanzania, that Professor Laku works with, managed to get down to 32% mortality, which is fantastic, and another 2 were down to between 45 and 50%. In real terms, there were 70 survivors from gastroschisis during the 2-year study period, and this compares to just 3 survivors in the 2 years prior to the study across those 7 sites. So I'd just like to sincerely thank everyone, huge amounts of people that were involved in all these studies, and the funders and all the teams that have supported it. If you're interested in reading more, the PeteSearch Africa study was published in BMJ Global Health. Of course, you can see the Global PaedSurg study results in the Lancet, and the Gastroschisis study, you can see the published protocol in the Wellcome Open Research. And any more information can also be found on the Global PaedSurg website and all our social media sites. So thank you so much for listening.